We're just going to do a couple of slides, give you a little bit of an idea of what our partnership has looked like, and then we're going to have lots of time for discussion. And hopefully you all have questions, and this will be pretty informal. So I'm Scott Demarest. I'm a pediatric neurologist, an epileptologist at Children's Hospital Colorado. You're going to hear from Melissa, who's the development director of STXBP1, and Yssa, who's the co-founder, treasurer, director of research. Got another couple of titles that you want to throw on there at Ring14 USA.
Every session, so I don't know what it is, but yeah.
So again, this is me. I'm going to talk about our Neurogenetics Multidisciplinary Clinic so that everybody has an idea about what we've tried to set up, and then we'll talk about what it was like for each of us to get to where we are. So our multidisciplinary clinic includes a number of different providers that all see a patient over a 2-day period. That includes, as you can see here, neurology, rehab, PT, OT, and speech therapy, genetics, special care, pediatricians. Not everybody knows what a special care pediatrician is. It's essentially a generalist, a general pediatrician who specializes in taking care of complex patients and is really good about being able to deal with multidisciplinary issues, coordination of care, and in my opinion are like the heroes of the world. A developmental pediatrician and a neuropsychologist. This is all sort of nested under a single multidisciplinary clinic, but within it we see 4 different disorders: chromosome 8p disorders, Ring14, STXBP1, and SLC6A1. So Melissa and Yssa are representatives of 2 of those disorders out of the 4, and we can kind of talk about how we got to this collaboration. It's a little bit of a funny stretch on this, but this is our huge team that we have to be able to meet the needs of our patients. I'm lucky and honored to be able to work with these people, and I'm going to call out 2 of them specifically. Dr. Margarita Saenz is my co-director along with me for the clinic. She's a clinical geneticist and wonderful human being. Tristan Dinkel is our RN coordinator, our nurse coordinator, and she's the ultimate herder of cats. She makes it all possible. She interacts with the family. She makes sure that we are not providing recommendations that are counter to each other and inconsistent. I know that's never happened in clinical care. She's really the powerhouse behind our clinic. So just to give a sense of what this looks like logistically, we have a clinic on the first and third Fridays of each month, half day on the first and a full day on the third, dedicated to this group of patients. It's multidisciplinary, as we talked about, and we try to see 3 to 4 patients per half day. So that gives you a sense. They're pretty long appointments. It's a lot. Families are there for a long time. We do that within a multidisciplinary space that has a little bit larger clinic rooms, and a family stays in one spot for half the day, and we all rotate through as the physicians, and we come in groups together so that we try not to make it so that families have to repeat themselves too many times. There's a little bit of repeating, but we try to minimize it. And then the other half of the day, they're in our special care clinic for just a regular 1-hour appointment. And the day prior is a neuropsychology assessment. And we had to separate that out to a separate day. For those of you who've been involved with neuropsychological assessments, they are a lot. It's time-consuming. It can be challenging for our kiddos, and we want to give them the best chance of being able to do it and feel good about it and do well. So this is sort of just a little bit more of a representation of what that looks like between our neurology clinic, where the neuropsychological assessment occurs, the special care clinic, and the multidisciplinary clinic. We would have loved to have everything happen in a single location. This was as close as we could get, is 3 locations over 2 days. So these are kind of our current totals. They're actually going to be about 2 weeks out of date, but they're pretty close to our current totals in terms of number of patients that we've seen with each of the different disorders. 31 patients with chromosome 8p disorders, 3 patients with Ring14. This is probably our rarest of the 4 And so that's part of that. 14 patients with SLC6A1, 36 with STXBP1. And we have 25 patients currently waiting to be seen that have been scheduled out over the next several months. This gives you some sense of what that looks like for rare diseases in terms of how do you make that work. Families have come from 27 states, far-flung as Alaska, East Coast, to Colorado to be able to do this. For several of these disorders, but not all, we're the only multidisciplinary clinic dedicated to them. Some of them are lucky enough to have other clinics as well. So when we approach this, we obviously want to have high quality clinical care, but we also wanted to make sure that that was paired with the ability to collect data and be able to learn from every patient who's willing to travel and come to our clinic. We also think that if you have a really structured approach to your clinical care, you actually provide better clinical care. So if you don't just kind of ask whatever random questions come up, but you go through a structured set of questions, then you're less likely to miss things and then therefore not address them, or be dependent on families to actually raise, hey, by the way, what about this? So when we think about that, there's a couple of pieces that I'm highlighting here that can be included in how we structure this. We have very structured clinical intake forms, so we ask families to fill out surveys ahead of time, so we have a sense of where is that patient, what kinds of issues are going on, what's pressing and top of mind for families. We have structured note templates so that we make sure we're not forgetting things as conversations go where they go during the appointment. We include that really comprehensive neuropsychological evaluation that happens the day prior. We've developed some tools for neurologic severity assessments that we utilize in this clinic that may not be perfect for all the disorders, but that's part of our learning process to understand how we capture and understand how neurologic manifestations change over the course of time. And then we can do certain assessments with our therapy group, like GMFM and others. This is an example of something that came out of us having a very structured approach. CVI stands for cortical visual impairment or cerebral visual impairment. If you're European, you call it cerebral. If you're American, you call it cortical. We like to make things confusing. So CVI is essentially where there's not an issue with the eyes. The eyes send signals to the brain, but the brain isn't processing that visual signal appropriately, and so there is some level of visual impairment associated with it. It's pretty common in neurogenetic conditions, and we've seen it in a variety of these conditions. And I'll also say, for some of these disorders, I'd never seen a patient before we started our clinic. So we have to grow experts. They don't just exist. And my experience with other neurogenetic conditions led me to say, let's watch for this in these conditions as well. So as we took a very structured approach, and it's all physical exam based, to look for signs of visual impairment, this is what we have seen so far across our 4 disorders. A little more than half in STXBP1 and 8P. It was right around half with Ring14, though again, small numbers. And this is a little bit older data, so we've seen more patients now with SLC6A1, but at that time it was a pretty small number, and we hadn't seen any patients with CVI in SLC6A1. And that's also valuable. So it's not just from a research perspective saying, well, it's not reported. Nobody's said anything about it. We can actually say, no, it's not present, right? And those are different in an important way. How do we do that, and how do we make that work? Well, Vanessa, that's how we do it. Vanessa Vogelfarley, everybody. She deserves a round of applause. Please, come on. So when this actually started with Bina Shah, who runs Project 8P, and Yssa, saying, like, we want a clinic in Colorado. And I said, that's really nice. You should have one. And they said, no, we want you to actually set that up. And I said, oh, yeah, I don't have time to do that. I can't do that. And they were persistent in the most wonderful way. And part of what I was worried about, because I had had experience previously with another rare disease, CDKL5, that I run a research network for, and have been very privileged to be able to advance some of our knowledge in that space along with many, many collaborators. I set up the research network in the traditional way. It took about 2 years to get IRBs at 9 institutions and be able to share data and have a cohesive process. And it was just all administrative. Like, I wasn't doing science. I wasn't doing clinical care. I was just banging my head against administrative walls to be able to get the infrastructure in place. And so I said, I'm not going to do that again. And I can't set up a different system for all 4 disorders. It's just not, it doesn't make sense. We need to be able to scale this and come to better efficiencies. And RareX was building at that stage. And so I said, Vanessa, if we're going to do this, you're my administrative burden, right? Like, you guys have to take this on for me. And she didn't say no, which is amazing. So the data goes to RareX. They house it. They help us with the regulatory side of things. And while they've done that for our organization, our institution, it actually is easier to advance to other institutions than my prior model. And RareX is in control of that. And as RareX has talked about in many cases, what's done with data that lives in RareX is up to families. So it also means I'm not the one controlling that data. And even if I have the best intention, it's not Melissa and Yssa going, come on, Scott, like, get the data moving. We need to do something with it. We need to do this. We need to do that. And I'm just too busy to do something. It's not under my control now. And for me, that was actually an advantage of this situation. Thank you, RareX and Vanessa. So that's my part. These are a huge number of people that are involved in this, large number of organizations that are supporting this work. And I haven't talked a lot about it, but we have a Batten disease clinic that's sort of a sister clinic to this one as well, and happens in the morning on the first Friday, that is also kind of being connected into some of that research infrastructure in an ongoing process. And with that, I'm turning it over to Melissa first, right?
Hi, everybody. I'm Melissa Hioco. I'm with the STXBP1 Foundation, and I'm also Alex's mom. He has an STXBP1 disorder, and I have not only had the privilege of working alongside Scott and Yssa, but I've also had the privilege of bringing my son to the clinic to receive care at the clinic, and also provide an opportunity for us to contribute for research. So as you can see, our partners, as Scott said, are Project 8P, Ring14, us, and SLC6A1. We are basically a coalition that we all aligned around building clinical expertise. And Scott kind of said that a minute ago, is you want a clinician who has the capacity to become an expert. And that's what we were ultimately looking for, somebody who was willing to become an expert in our diseases. And also somebody who was willing to help with the research around our disorders. And we found that Colorado had an amazing reputation for doing partnerships and for working with teams, and had that multidisciplinary approach already. And it seemed like a good fit for our communities and for this partnership to be able to work. So we partnered with like-minded advocacy groups. And by doing that, we were able to actually share the burden, share the cost burden amongst our groups. So not all of the cost was put onto one of us, but rather it was shared amongst all of us. And also, if you think about it, when we put all of our efforts together and we really are able to capitalize on, what we can bring together as partners, we can take this further than we would be able to do individually. So it was really amazing that we were able to create this partnership and take it as far as we have, and hopefully even further. Oops, sorry. So this is our newest picture of our community. We actually had a conference in Colorado, and a lot of our families here were able to go to the clinic while they were there in Colorado. And our mission statement, which is probably similar to many of yours, is support development of a cure for STXBP1 and support patients and families today. So how are we able to do that within this partnership and within this structure? It's critical to develop that clinical expertise to support our kids. And that's what we have set out to do. And again, you may not have an expert at that moment, but you can build that expert. And if you have somebody who is willing and a team that's willing to do that. So many families see the clinicians who have little to no experience with rare neurodevelopmental disorders and maybe have had no experience with STXBP1. But again, we're building that clinical expertise. That multidisciplinary team approach is ideal for our patients. A lot of members are involved in their care. A lot of team members are involved in their care. And also, clinical expertise needs to be available and accessible to all patients and families. So this is where, again, we just needed to build that clinical expertise, and this was a way that we could do that for our families. And then a little bit more on supporting the development of a cure. So how could this help us in the development of a cure? So it was valuable to have that clinical care paired with the research for both the researchers and the families. Basically, we were, being able to accomplish more within that clinic setting. And so families are not just giving, they're also receiving during that time. And I can say that when we attended the clinic with my son, it was definitely that type of approach. We were providing them with the ability to become experts and learning, that they were learning from us, but then we were also giving, in that we were giving information and data that would be helpful in research efforts. Clinical care and research, I think Scott said this, walk hand in hand. And we've seen that already. Scott showed you the CVI slide. I mean, we're already seeing some of these things come out of the clinic, out of the research in the clinic that are walking together. And then it also streamlines the hospital and clinical time, and it helps, it's not two separate things. It's all done within that one appointment, although it is a long appointment.
It is.
It's if you're going to take the time, then it's definitely streamlining it for our families and for our patients. It also increases our research participation. They're going to see a clinician who's willing to listen to them and to become an expert, but they're also participating in research. And so we're really doing both at the same time. And we're doing the assessments, the evaluations like Scott talked about. And also we have the practical application that can be taken back to the schools and therapists. The report that came out of the clinic visit, we were able to use it in a real world setting where we could take it back to the school or to their therapist and say, here's what we found, here's things that we can do to help him. And that was valuable for us. And then the last thing is collecting that standardized data for STXBP1, but also looking at it across the disorders. And again, in the CVI slide, you saw how we're starting to do, look at it across the disorders. And then providing a better understanding of STXBP1. I think that's been really a goal of ours for a long time, right? Is to understand STXBP1 and to be able to help our kids. And so, on to you.
Okay. So I'm not going to repeat a lot of the things that Melissa has said so eloquently, but the point of the matter is most times all of our mission statements play into research and support, and hopefully we're giving the community back something that improves their care now. So here's our mission statement. I'm sure it's similar to some of y'all's, but the point of the matter is the clinic and the research play right into that. And there is our community at our family conference this last year in Morgan's Wonderland. So I'm going to talk just a little bit about how this partnership began. Now, Scott's hit some really excellent points. I'm not going to I'm going to try not to say the same thing twice, but I really want to emphasize just a few things. And one is that we didn't, we just didn't pick a random children's hospital, right? It was very intentional. And they had a proven track record with very similar type syndromes. And so we knew that they were going to be comfortable seeing the complexity in our children, and that they would have insight, because that's all they see is this complex care. That's very different than Marie, who sees a local neurologist who has, 10% of her practice being really complex kids, but almost all of their practice is that, and that's a huge advantage. So, but also this institutional support. Guys, we did a survey with clinicians who run these multidisciplinary clinics, and we asked them some of the barriers in a survey that the Rare Epilepsy Network did. And one of the main things that they noted as a barrier is institutional support. And so the fact that Children's Colorado already had a multidisciplinary clinic was huge, because it meant that their institution as a whole was supportive of this type of care. And I'm going to go further than saying multidisciplinary, because sometimes people think, neurologist, geneticist, and neuropsych, that's a multidisciplinary team, and they're not wrong. It's more than two. It's multi. You know what I mean? But this clinic really is multi-organ, multi-system. Okay, and they all talk about the care together. Okay, so they had experience. They already did this, and they had Tristan, who'd already been a nurse coordinator for another clinic, who knew how to do all of the headaches that go along with Medicaid across state lines and things like that. Guys, there's a huge learning curve there. We were tapping into that, very intentional. And who are we kidding? Bina was so persistent. Oh, I love it. She just do it. And she wore Scott down. And guys, sometimes it takes that. It really takes that person who is not gonna say no. So that's not always me, but Bina is, and so I'm so glad that she's in our flock and that she played that role. So that's good. So the organizations, so the commonalities were symptoms and specialties that we need. But guys, I'm gonna nail on this data structure too, because it's so huge that we were able to tap into a similar data structure, facilitated by RareX. Then we do a large portion of building those pipes to Vanessa. So Scott was kind of poking at her a little bit, but a lot of sincere thanks there. And it also was not free. I want to point this out. Our grant with CZI paid to build those pipes. And that was money World paid, but that's money that other people, those pipes are built, okay? So that's all of us helping each other with a vision for what we do that translates across, that we want to, we just need to tap into that as a community, that idea that what we build can be used by other organizations, and that's okay. And in fact, it's fantastic. What else? Oh, guys, one of the things, so Scott said something about, I'm not going to build 4 different clinics for each one, but also he doesn't want to have 4 different agreements with each of us, like financial agreements that have to go through lawyers and all of this. So I do want to point out that we only have 1 contract with Scott, okay? And who's the bank has changed. So 8P was the bank the first year, and then XTBP1, blah, 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 but this fine lady, they're the bank this year, okay? And but we all have an understanding between the institutions, and so they're the bank, but we pay them. But that simplifies Scott's life and how we interact, okay? So it works, but what it also takes is a lot of trust between the organizations, okay? So you pick your partners with care. Okay, you pick your institution with care so that all of this works and that you're able to simplify this stuff and make it easy. So, if you build it, will they come? And I was so thrilled about this clinic and being able to offer this to the community, and I think we all felt that way. And it was slow to be adopted in the Ring14 community, and there's a couple of reasons. Scott said really small, okay, only have about 25 engaged families in the whole United States, and they're spread out all over the place. And we know that not all of our families in our community are always 100% engaged, okay? So you have to do a little bit of work to get these clinics to be picked up by your community. And so I encourage, one, if you're gonna build something like this and you're a parent, then you have to lead by example. So Melissa's been to clinic, me and my daughter have been to clinic, all the leaders have been to clinic. You wanna know what your families are gonna experience in that day. You wanna know what the hiccups are, where the time is spent, all of these things, but also you want to be able to see the value yourself. And when I went to clinic, I thought, I'm being a good citizen, I'm being a good leader.
Me too.
What I didn't realize is that it was going to change my daughter's care. Like, I thought I'd sought out the best care all over the world, this and that, but I'd sought out care that was like this all over the place. This was my first experience going to a multidisciplinary care, multi-syndrome care, where everybody gets in there and they actually talk collectively about your daughter's complexity or your son's complexity before they build that plan. And something major came out of her care that I was not really anticipating. And we decided to attack sleep as opposed to the seizures, which are always the target. And it had a huge quality of life improvement, not only for my daughter, but for me, okay? So I just wanna say, we can preach about these clinics, but when you experience it and you go, damn, that worked, that's pretty exciting. Okay, that's pretty exciting. So then you have to go back and you have to share with your community what worked, okay? You can't keep it a secret. You have to share, we had a very immediate effect, but we're also participating long-term and we see the benefit of that also. There's gonna have to be a little bit of education around these coordinated care plans because some people aren't used to them. How do we use this? Is Scott gonna be our permanent doctor? You know what I mean? And that's not really the model. The model is that you get really good plan to take back to your local physicians, and then Scott and them serve as like a support. But you also get tools that you can use immediately, like the neuropsych. You're going to be able to use that at your IEP meeting with the school system. So our idea is that we wanted the families to see immediate benefit and not just a research, right? Not just that. We're going to give you something right now. One of the things that's been really good for Ring14 is we had Scott and all the team come in and come to our family conferences. And so we had 3 families who went last year, and I think now we have like 5 families on the waiting list, okay? Because they meet Scott, they meet the team, everybody talks together, and it becomes, you know, they pick it up in the community. Guys, had a whole 2 sessions about equity and inclusion. Guys, this is a very privileged thing to be able to travel all the way across the country to go to Colorado. And there are certain, we as a community cannot pay these medical bills to do this, okay? So you have to rely on insurance and things like that. Scott's team does a great job working with Medicaid waivers and all of this. They jump through hoops to let these kids come and cross state lines as best they can. One of the things our organization does is we have a medical travel scholarship as well, so that if they apply, we give them funds to cover travel so that at least we alleviate that burden. So it's something to think about if you're going to ask families to come that far, that not everybody has to take it, right? But we want to make sure it's accessible to our whole community. And then once again, guys, this people talking about their experience, that's what's going to get it to rise to the top. And I think that we've gone through everything. Or we have maybe questions. What are we doing, man?
We have some things that we are happy to talk about in sort of points of how do you get to this if you're interested. But we also will welcome this to be interactive at this point. So if you have questions or comments, we've got 13 minutes left, and we can go whichever direction you guys want to go.
All right. There we go.
Yep, should be good now.
I think you're good.
Wes Rogers with Sertra syndrome. We have 3 patients here in the U.S., and then 31 identified around the globe, 11 in our immediate community group. I'm curious, are there any international patients in y'all's communities that are involved in the data sharing and that are participating in this?
Do you want to speak?
I'll let you.
Well, so we haven't, you asked kind of different questions. So the data part of this is a little bit separate. The data is housed in RARE, so you can participate in that setting with data collection that way. We had and international family at our conference. They were assessed and all of this. As far as getting families to clinic, I'm going to let Scott confirm this, but I think that there's been a number of, not a number, but a half dozen families, not from our organization, but from...
There have been patients who have come from international locations to our clinic. That's obviously even a little bit more complicated from an insurance standpoint and those sorts of things. It's not just the further travel, but it's been possible, and we have had some families who have come.
Hello. So I'm wondering, how do I find you for me? What would be like a first step to finding this type of information?
Was one of our things. Yeah.
So I'm going to answer that a little bit, but I'm also going to invite both of you to respond to that. Because part of it is I can offer what facilitates this from an academic's perspective. One, persistence isn't a bad thing. Part of that persistence was also time for us to build a relationship and to build the trust that Yssa was talking about, that I think is really critical. I want to be able to do something to help everyone. I want to be able to take care of all of your children. I can't. It's not possible. So you build relationships, you say, okay, we can do this. Some of that was setting certain boundaries on both our sides that I had to sort of say, like, this is what I can do and what I'm capable of, and there's certain things that I can't do because I don't want to say I'll do something and it not be possible or do it badly. This group was really incredible about coming together to take some of that burden off of me. And that made this easier and more possible for me to be able to participate in. So I think some of that is kind of how are you working with clinicians who are really busy and they're pulled in lots of different directions. How do you say, listen, we're going to take care of certain things, like we're going to work with this group to take care of the research pieces of it. We're going to work together to make sure that we can fund this in a way that actually makes this sustainable for you. I think those are all pieces that are just part of the reality of how we can get to there. And I was really lucky that they were willing to do all of those things to make this possible for me.
I'll say a couple of, let me just add on just a couple of things. You know, I met Scott at a professional conference. I met him at the American Epilepsy Society. Another person at Colorado had done a clinic for CDKL5. Karen Utley was involved in these clinics. When I met her, I was like, I need her as a friend, and so then she shared this clinic structure with me. We knew Scott was involved, and might have had a couple of drinks together talking about the possibilities of all of this.
Good strategy.
But the point is that these things are relational, okay? These things are relational. And we all really talk a lot about, researchers and open data and all of this stuff. Guys, we can't be that proprietary about our researchers also. This is a two-way street, okay? So you have to be reasonable, and you have to share, and you have to figure out where things align that work for both. You know what I mean? Scott had the capacity and he had the experience, but if we hadn't met him at AES, if I hadn't been friends with Karen, and if I hadn't become friends with Bina through Vanessa, none of this happens. So this work that you're doing in this room and at this conference, it's the secret sauce, guys. These are the connections. This is the networking, okay, that's so crucial. And now Yssa may have something to add because she's replicated this at other places. So what would you?
Not by myself.
I know, but.
So we are privileged to have 2 clinics, and we are actually in the process of adding 2 more. So we ultimately will have 4 clinics. However, I would say that Colorado has the largest team in the multidisciplinary clinic that we have to date. So it's the most comprehensive team. For what I would say to the question is, are you already connected with somebody who's compassionate and who is willing to work with your organization? And then find other organizations that have similar symptoms, their children or patients have similar symptoms, where you could create a team that could help to address all of the disorders and find those like-minded organizations to work with. I think one other thing that we have found in looking at these different clinic sites is we have found challenges in working with some of the institutions. Not all of the academic institutions are as open and willing to create a model like this. And so that's another thing that you need to be looking for. Do they already have a model like this in place? Colorado did. But if they don't, you may be the first, and this may be a challenge. So maybe look for those places that already have them in place, but also who do you already have connections with? Like what Yssa was saying, who do you already have connections with? And how can you make this desirable and appealing to that institution and to that clinician so that it's something that they want to move forward with?
The last thing I'm going to say is be open to junior doctors, junior faculty. Again, we're growing experts. If you're going for that super well-known, illustrious professor of blah, 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 they don't have any time. They're already split so many different ways, whereas someone young can really put a lot of effort into it. They build their career and their expertise around that process. And so I think it's a win-win all around. And so be open to people who are less well-known. Sorry, there's a question over here.
Okay.
Okay, technically I don't have a question. I just wanted to say I'm here on behalf of Dirk-Winne syndrome. If you guys are curious, we have our booth right out here. But I actually live in Colorado Springs, and all of my doctor's care is through Children's. So I just wanted to say that you're a great organization. I have nothing but good things to say about you. You know, you hear all these horror stories about doctors that do this and do that, and insurance. And through the Children's Colorado, I've never had any of those issues. So I just wanted to say, good job. And you'll probably be hearing from me about Dirk-Winne. There's about 7 or 8 people in Colorado with Dirk-Winne, so don't be surprised.
Oh.
I'm glad it was a positive comment, better institution.
Leave it at that.
Hi, Kristen Anderson with the VATPACE Alliance. Kind of a build on to her question is you know, I see the obvious value proposition for the families and the patients of doing this type of multidisciplinary clinic, but could you speak a little bit more to, like, from your perspective and the institution's perspective, what is the value proposition that makes a Colorado Children's or any of the other clinic sites want to do this kind of thing?
Yeah. I can answer that from 2 different perspectives. One would be sort of as a clinician and researcher, you get to go a little more in depth. As I mentioned, some of these disorders, I hadn't actually seen a patient with them before we opened the doors on the clinic, and I'm supposed to be the expert on it. I'd seen similar things. It's not like I was starting from scratch, but you get to, when you've seen 5, 10, 20 individuals with the same thing, you start to see patterns. You start to put certain things together in a way that you can't when you are only seeing ones off and twos offs, you know, all the time. And that's really rewarding. It builds to research. It builds what are the right research questions, what kinds of things do we need to be thinking about and focusing on. And I think for many people who are academic clinicians, like that's why we're doing it. That's why we're not getting paid way more to go, you know, be in private practice or industry or other opportunities that are out there. So that's the stuff that we like and gets us up in the morning. I will say, from an institutional perspective, it's a little bit more challenging. These are clear opportunities around reputation building, and demonstration of excellence, and, you know, U.S. News and World Reports, and all these kinds of things that institutions care about. But they're also trying to do that for every type of disease there is, right? And so why this particular disease can be a little bit more challenging. And despite that there is financial support around this, it's not like a lucrative thing for the institution. They're still actually investing significantly also to make these types of things possible. And so I think it's important to craft around what's the spin-off from this. When you set up a clinic like this, CDKL5 is a great example where we've done this for a little longer. That clinic's been in place for more than 10 years now. We have NIH funding that we've received associated with that. So we've been able to build on that to get to bigger grants with IFCR, International Foundation for CDKL5 Research, acting as sort of our seed to get that going from a grant perspective. It gives you the opportunity to be a site for clinical trials because you have that expertise and the connections with families. And that can be valuable, again, for reputation, but also is a little more sustainable from a financial perspective, right? There's downstream impacts that really create opportunities when you have this, and it's important for your institutional person to know how to champion that internally to build that buy-in with their institution.
Just off of Scott's comment, I just wanted to say that ultimately our goal is to have Colorado and our 3 other sites as clinical trial sites as we move forward with research. So we're already moving in that direction. And we talked about accessibility earlier, and in our eyes, we already had an East Coast clinic that was up and going. This was now providing that accessibility to families on the other side of the country. So now we have an East Coast and almost West Coast, clinic. I'm in California. I was very grateful to have a clinic in Colorado. I can't travel all the way to the East Coast with my son. So this made it much more accessible. But also, when we get to clinical trials, my son could potentially be in a clinical trial, whereas it would have been too difficult for us to go to a clinical trial on the East Coast. So ultimately, when we're able to create these centers and duplicate this model at different sites, it does open you up to potentially providing that access for families to participate in clinical trials.
Yeah, just a quick comment here. I'm Carol Bacos, and I'm representing Jordan syndrome. And I'm also wanted to share our story because we also live in Colorado. And we're thankful to have this great resource just down the road that we don't have to travel to. But last year at the RARE Summit, I met another doctor from the MDC clinic at Colorado, and we talked about, you know, her experience, and I talked her into seeing my daughter into the clinic, and we did as soon as we got back. It was the best experience in the 10 years that we've had, and as someone that like walked away from appointments with nothing new, that was such a value add experience. I was so happy to walk away with a long action list, which was different in the last 5 years. That hadn't been the case. And now Jordan syndrome is added to the MDCs that Colorado children sees. So thank you for creating these channels, and sometimes it's just finding the right person and begging your way through.
It's awesome. I know Vanessa's going to kick us out, but I'm going to say one more thing, and that is because I want to go back to your question, because guys, we have some work in the field to do here, because making a case for this means making a buyer's case, and the way you do that is you show that all of this satisfaction with families, which is so high, translates into things that we can actually, you know, we need endpoints to mark the success of these that show that it improves quality of care, that it improves lives and stuff like that. That's something as a community that we need to do if we really want uptake of this multidiscipline, multi-syndrome care.
Okay.
I agree with that comment.
Okay.